Hi, everybody. Welcome to PermanenteDocs Chat. I'm your host, Dr. McDonald. I'm very excited to welcome our guest today, Dr. Sinsky from the American Medical Association. And we're going to talk about the impending physician work shortage. We have next week is National Doctors Week, and we're going to talk all things medicine and workforce. So Dr. Sinsky, we're going to jump right into this. So thank you so much for joining us. You have a lot of experience and background in this area, and we're really excited to learn from you. If people have questions during the chat, please drop them in the text box. We'll try to get to as much as we can, but we're going to try and keep this short and high yield. So Dr. Sinsky, thanks for joining us. Tell us really quickly kind of who you are and what you do.
Yeah, thanks, Alex. I'm a general internist, practiced for 32 years in Iowa, and I now lead a team at the AMA. And our mission is to help to create the conditions where joy, purpose, and meaning in work are possible for physicians and their teams. So in a nutshell, that's what we do.
Great. Just a small task. Should be super easy to take care of, right?
Yeah, we've got it down.
Well, tell us, a lot of people aren't aware that we're facing a physician shortage. So tell us kind of what we're seeing right now in terms of the workforce and physicians coming out of medical school versus retiring. And then also tell us how the impact of the pandemic and COVID-19 has exacerbated this kind of already bad situation as well.
Right. So I'll tell you that pre-pandemic, I always wanted to reframe the question. It's not so much a physician shortage problem as a physician utilization problem. And so we have physicians who spend 2 hours on the EHR for every 1 hour of direct FaceTime with patients, for example. So that's a physician utilization problem. And in many ways, we can hire back our own physicians by releasing some of that capacity to actually do the work that physicians are uniquely trained for. So pre-pandemic, it was primarily a physician utilization problem. I think with the pandemic, we still have this bill coming due where physicians and really others have kind of stood up to the plate for the challenges of the pandemic, but have been getting ready to exit, either to reduce to part-time or to leave medicine altogether. And I think that's the big question is what will happen as the pandemic kind of settles down and physicians say, I could do it for that time, but this is too much. I cannot keep at this pace.
Yeah, I think that's a really good point. I know a lot of my colleagues in general have cut back to part-time, even before COVID, just because of that balance between giving so much of yourself at work versus home and making sure you have that sustainability. We talk a lot about sort of work-life balance, but I don't really like that term personally, because it's about sustainability in your professional life. It's about sustainability in your personal life as well too. And I like thinking about being more sustainable. And I think the current workload is probably not sustainable for most doctors, particularly I'm biased obviously as a family physician in primary care, and I think primary care in particular feels the pinch from this pandemic in all areas as well too. Do you feel like any kind of existing problems have sort of been exacerbated by the pandemic specifically, and can you go into more details about what those might be?
Sure. So I think you're absolutely right that physicians, and I would say specialists in primary care, like yourself as a family physician or myself as a general internist, have long felt that we are spending our days doing the wrong work for our patients when we're doing so much administrative work or work that someone with a lesser amount of training could do, order entry and prescription renewal work and some of the visit note documentation, forms completion, that kind of thing. And I think that problem just got exacerbated by the pandemic, and many things happened. I think the workload got worse for many physicians. The staffing got worse as well, because there's been a great resignation among the clinical support staff. So medical assistants and nurses are in shorter supply than I believe they've been for decades. And the absence of those team members has resulted in even more work placed on the physician. So I think those are several things. I'd also point to a lack or an increase in politicization of care decisions, and a decrease in the civility in the conversations that some patients and families are having with their physicians around COVID-related issues.
Yeah, I think that's a nice way of saying it. It certainly has increased the nuance and sometimes the subtext of those experiences we have on a day-to-day basis, and can make it much harder too. And I was wondering how long it would take us into this talk to talk about the Great Resignation. Now, is that sort of term referring mostly to sort of nurses and ancillary staff, or does that sort of include physicians when we think about that term, the Great Resignation, so to speak?
Right. I think that's the question we don't know the answer to yet. What will the impact be on the longevity of physicians staying in their profession? It's a term, the Great Resignation, that really applies to the broader US workforce. And I earlier today found data that 43 million US workers, not just healthcare workers, but 43 million workers have left their jobs in the last 15 months. Oh, wow. With the highest number being last November, when just in that month, 4.5 million left. Talk to any health system leader and they will say they have many more nursing openings than they have applicants. They have more unfilled positions than they have had in years and years. So I think that we are seeing this problem broadly in the US workforce and more narrowly within the healthcare workforce.
Yeah, that makes sense. So we have a question here in the chat, actually, to kind of going back to that physician utilization phrase. So the question is, I like physician utilization problem better than sort of a staffing shortage, so to speak. We've known that for years, and what will change, I guess, and maybe I might add to this question, what are some of the things that the AMA is doing to try to address some of these utilization issues?
Yeah, so that's a big part of what we do at the AMA in the work that I lead. And we do that in the realm of research. So we have been able to identify prevalence, drivers, and consequences of burnout. And those are things that are really connected to this misuse of physician resources. Mm-hmm. We've developed a great number of tools for intervention, for doing the practice fundamentals where you strategically delegate work to an upskilled team, and where you de-implement policies that are outdated to get rid of sludge. So we have, for example, Steps Forward toolkit on Steps Forward is where we put all of our, under that umbrella is where we put all of our innovations. And we have over 70 practical toolkits. One of them is getting rid of stupid stuff. And it gives health system leaders, unit leaders, practical step-by-step instruction on how you can implement a getting rid of stupid stuff program in your sphere of influence to remove some of that sludge. Others of our toolkits are on how to do advanced team-based care, where you are able to, as a physician, share some of the tasks with your team rather than being the only one who does them. We do quite a few more things, but I'll let you know those as we go along.
I'm writing that down, getting rid of stupid stuff. I'm putting notes right now. I love that. I know for me personally, as a physician, the things that sort of make me most frustrated are those things that I feel like I don't have any control or training in. For example, forms for work. A lot of patients bring me these forms, and I'm not an occupational physician, and their employer says they need this form filled out by their doctor, but I don't necessarily know how to fill out this form. So things like that, a lot of those bureaucratic tasks where we as physicians feel like we don't necessarily know how to treat that or what to do with that, but also we want to help the patient at the same time, and then the patient ends up getting stuck in the middle, just as a small example. But I think there are a lot of examples we can think about it, and we don't want to go into too much detail there. Tell me, I want to kind of going back to this sort of physician utilization issue. I know, at least here in California, based on population growth and projected retirements of primary care and family physicians specifically, we're expecting about a 4,000 physician shortage by 2030 in primary care here in California. Is that something that's sort of reflected nationwide? And are there any sort of geographic or specialty areas where we feel like there's a worse utilization of physician time and resources. Is that a fair way to put it?
Sure. So I think both things are related, and that is that the projected shortage is projected to be greatest among the primary care specialties. So the AAMC has released last year a report suggesting that excuse me for just once. So they released a report suggesting that there would be up to 124,000 physician shortage in the next 10 years. And that shortage would be highest among primary care physicians, and up to a 48,000 physician shortage in primary care physicians in the next 10 years. And I think that is directly related to the physician utilization issue. That if you were to look at the inbox volume for primary care physicians, we know that it is much greater for our specialties than it is for some of our colleagues. Oftentimes, the amount of clinical support surrounding the physician is much higher in higher revenue specialties than it is in primary care specialties. All of those are fixable problems. We just have to decide that they're worthy enough to fix. And one of the ways that we're making that case is to make the business case for what it means to a healthcare institution, what it means to commercial payers, what it means to the U.S. healthcare system to have sufficient physicians, and particularly primary care physicians.
Yeah, no, I think that makes perfect sense as well. And it's been sort of a multifaceted problem, which has sort of been brewing for decades, so to speak, as well too. So we have another question here in the chat here, a little bit of a non sequitur, but I think it's somewhat related too. So do you think that defensive medicine, aka fear of malpractice, is part of the reason why physicians are not as good at maybe delegating some of the work and utilizing some of the resources around them so they can kind of, again, practice sort of at the top of their license as well? And is there any work AMA is doing in terms of around the laws and the fear of malpractice as well?
Sure. So I do think that the questioner is correct that there are many reasons why physicians have historically been somewhat reluctant to delegate work. I would put the reasons primarily at the skill level of the team member and the stability of that team member. Mm-hmm. I think there is also a feeling that if I didn't do it myself, it won't be done properly. But I think if we get a systems mindset, we'll actually find that many things are safer if they are done by an upskilled team member. So that one of the myths in our in the medical community is the task is always safer if the physician does it. I know that my nurses were much better at doing order entry than I was, because they were doing order entry as the single task they were doing at the time, where I would have been trying to do multitasking at the same time. So to the extent that physicians are worried about making an error, I think it's important to look at, do we have the right skill level? I happen to have been fortunate to work with nurses, RNs, as my partners in clinical care as an internist, as did our family physicians in our organization. And do we have enough of them? A half of a medical assistant per physician is simply not enough to do the work well. That ideally we have closer to 2 or 2.5 medical assistants or nurses per physician. And there's a good business case for that. We just have to make that case.
Yeah, I always like to say that, I practice sports medicine as well. It's my sports banner up there. And I always like to say that medicine is a team sport. And I cannot tell you how many times that nurses and MAs and pharmacists have helped me do my job better if they've caught an error or a mistake. And I think it's so important that we sort of, as physicians, we're trained as sort of being, solo entities, the judge, jury, and executioner, so to speak. Maybe a bad example, but I think we have to learn and retrain our brains. And I think medical students graduating now are better trained in sort of systems practices than they were, probably even 20 or 30 years ago. But I think that's such a great point in terms of just relying on the team members and making sure we have enough team members too. Tell us more. Now, we all worry about, we know the costs of medicine are just unsustainable, and the financial burdens on the whole system is reaching a breaking point in many respects. Tell us, what are sort of, when you have a physician who's cutting back their hours, we spend a lot of money training our physician workforce. What are kind of the financial costs to, not only physicians kind of cutting back their work hours, but also physician burnout or leaving the workforce altogether?
Right, right. Well, a couple of key statistics that I'd love to share with you. One is that for an organization, it costs between $500,000 or $1.3 million to replace one physician who leaves.
Wow.
And that's a pretty conservative estimate. We know that, so that's the cost to the organization. The cost to the payer, whether it's the patient or the commercial or public payer, for a primary care physician, the current turnover costs nearly $1 billion every year in excess healthcare expenditures when a patient loses their primary care physician. So when a patient loses their doc, they'll go to more expensive sites of service, or they may see someone who's less familiar with them, and that person will inherently order more tests, or there might be some drop off there. And so we know that that costs nearly $1 billion. And we used very, very conservative estimates when we put that together. And we know that about a quarter of that is attributed to primary care physicians who leave because of burnout, not who leave with burnout, but who leave because of burnout. And so right there is a pretty strong business case for addressing this issue. Separately, using existing data in the literature, we found that burnout costs the US healthcare system $4.6 billion a year, just in terms of physician turnover, and had nothing to do with these excess expenditures that I just mentioned. So as a health system, and writ large, and as Kaiser, still large, but not the full of the US healthcare system, we are already investing millions and millions of dollars every year on burnout. We're just investing it, replacing those people who leave. If we invest a fraction of that upstream to prevent leaving, we will, I think, have a much better outcome. And we lose about the equivalent of the graduating medical school classes of 40 medical schools every year due to burnout. Wow.
That's amazing. I knew that was a big financial impact, but I didn't realize it was in the billions and billions of dollars. That's amazing. Wow. What
and I just want to correct that. That's 40 medical schools over a 2-year period of time, but it's still a large number. So we're spending a lot of effort training more, but actually, if we spend some effort having fewer people leave, we will also help solve this problem.
Right. It's the in and out problem, sounds like, as well. Right. It needs to be addressed from both aspects. Tell us, I mean, and this is likely a question we can go on forever and ever, and I want to wrap up here in the next few minutes just to keep our time short. I thank you so much for joining us. What are some things, and I think this is likely multifaceted, what are some things that physicians in practice can do to reduce their risk of burnout? What are some resources that AMA is providing? I know here at KP we have a lot of tools and resources for our physicians as well too. But from kind of more on a global scale, what are some things that physicians can do, and that their friends and family and staff can do to help support them and to reduce the risk of burnout as well?
Sure. So first, I think about 80% of burnout is related to systems factors, to organizational culture and practice efficiency. So we need to remain focused on the fact that the key issue is to fix the workplace rather than fixing the worker. The worker isn't broken, it's the workplace that's broken. That said, there's a lot that institutions can do to support individual self-care, and things that we as individual physicians can do. So we can make sure that we've done what we can in our sphere of influence to reduce waste and to improve the efficiency of our practice. And we can set boundaries. And we can set boundaries about, I will go this far, but I won't go further. I will give this much of my time to after hours work, but I am not giving 2 hours to pajama time every day. I think the unfortunate thing is that many physicians have coped with one of the few levers we've made available, and that is to do what your colleagues have done, to cut back to part-time. But if we look at what's happening, those doctors are working full-time hours. They're just getting paid part-time wages.
Yes.
And so we have to think about the equity issue involved in that. So individual physicians can play a role, health systems can play a role, and then the larger US healthcare system has an obligation as well.
Yeah, I think you're spot on there when you talk about systems. I have a friend of mine who likes to say that no amount of yoga is going to help him get through his day better, right? Yes, it's an important piece, but it's really building that system around the physician and the workforce to make sure we're all supported and can have that joy in practice as well too. So, all right, we're going to wrap up here. One last question, real quickly. Tell us what makes you most proud to be a physician at this moment in time.
So I don't think there is a better profession on earth than being a physician. It is chock full of meaning. And I am so proud of all of our colleagues who have really stepped up to the moment of COVID and have researched the issue. Our research physician colleagues who have worked in the throes of the unknown and who have stayed the course. And so I am proud of our physicians and our physician colleagues with how they've stood up to this really unique challenge.
Wonderful. Thank you so much, Dr. Sinski. Really appreciate all your time talking to us today and everything you're doing at the American Medical Association as well. Make sure you tune in and join us next month. We don't have a date yet, but make sure you stay tuned to Facebook, and we'll make sure we talk more soon.
Thanks Alex.
Thank you.